The Healthcare Labyrinth podcast is back for another episode. Join Mark S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth podcast. My name is Mark Ryan. It's a pleasure to be hosting the podcast, and thanks to everyone for listening in. Today, we are talking about the looming cuts and how Congress is looking to thread the needle on reductions to spending that have as little harm as possible on coverage in Medicaid and even in Medicare. I have touched upon many of these topics in earlier podcasts, talking about possible cuts to healthcare. And in other podcasts, I've told you why some of these reductions make sense to reform the healthcare system as a whole. But I am repeating some of them again to show how the package that may be put together in Congress for budget reconciliation will pull in all sorts of reductions that seek to, again, thread the needle I was just talking about. Let's get into a little bit of background here on the budget reconciliation process. Well, recently, in a very tight vote, the House GOP caucus passed, without any Democratic support, the budget reconciliation framework in the House. This is meant to clear the way to extend President Trump's 2017 tax cuts, which cost trillions of dollars over time. But it also puts in place a $2 trillion cut goal over a 10-year horizon to help pay for the tax cut extension. One of the committees that has to institute major reductions is the House Energy and Commerce Committee. It has a great deal of cognizance over healthcare. And it is tasked with an $880 billion spending cut bogey over a 10-year period. Well, the Congressional Budget Office recently came out and said, hey, listen, there's just not enough cuts in other spending that is under the committee's cognizance to hit that $880 billion target. So consequently, the committee would have to cut Medicaid and perhaps even Medicare to hit the target. But as we know, GOP leaders in each chamber and President Trump have given commitments publicly that Medicaid coverage will not be cut. That seems to take off the spending cut table a massive restructuring of Medicaid, as well as even overt reductions in percentage reimbursement to states. But the GOP is arguing that it will take a bite out of the size of Medicaid by eliminating fraud, waste, and abuse, and instituting work requirements. On the fraud, waste, and abuse front, whether you use estimates by government authorities or external think tanks, the numbers are clearly huge. External parties tend to think FWA, overpayments, and eligibility errors are much greater than what government calculates. For example, the Paragon Health Institute, a conservative think tank, says the improper payments under Medicaid could be as much as $1.1 trillion over 10 years, while the Centers for Medicare and Medicaid Services estimates improper payments at around $543 billion over 10 years. There were also some commitments made by Trump during the election campaign and some other GOP leaders not to fundamentally cut Medicare as well. The commitment there was even deeper than in Medicaid. They essentially said they were taking Medicare cuts off the table. However, some more conservative lawmakers have argued there are opportunities to cut Medicare, and it needs to be put back on the table just given the size of the cuts that are being talked about. They argue it would be fiscally irresponsible not to. And the focus area here from some of these conservatives are on what are known as the Medicare Advantage overpayments. We've talked about this in the past as well. They view overpayments in Medicare Advantage as corporate welfare, and they think this is an opportunity to make reductions without violating the Trump campaign promise. So let's talk again how the House E&C committee might get there in terms of cuts and not violating the political commitments. I'm going to break this podcast up into 3 sections: Blue Cross and Blue Shield Association proposals for reductions, possible Medicare Advantage overpayment cuts, and thirdly, a new topic that I don't normally talk about: provider taxes in Medicaid and how those might be adopted as part of the fraud, waste, and abuse initiative for Medicaid cuts. That gives us a chance to break up the podcast with 3 breaks as usual. Each of the topics appears more focused on provider and health plan cuts rather than overall coverage cuts. It is, again, an effort to thread the needle on savings and commitments not to fundamentally change Medicare or Medicaid. Of course, there will be impacts, but could these cuts pass political muster and achieve spending cost reduction goals? We will go to break 1 now. When we get back, we'll get started with the Blue Cross and Blue Shield Association, largely provider and health plan cut proposals when we get back. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Mark Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Mark dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage and a private delivery model. Mark is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Mark's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We're talking about possible cuts during the budget reconciliation process that will thread that needle, achieving cost reductions in the federal budget without violating political campaign promises to not fundamentally impact Medicaid and Medicare. So our first segment here is going to be what I call the savings guide from the Blue Cross and Blue Shield Association and how it could be worthy of Congress's consideration here. Again, focused more on just generally provider and other cuts and not fundamentally attacking coverage. So the Blue Cross and Blue Shield Association is the national sort of lobby group and association over all of the individual Blue Cross and Blue Shield plans in the nation. And it has issued a very good report on reasonable healthcare savings that could save nearly $1 trillion over the next decade. I have raised a number of these issues in past blogs and podcasts, but I felt covering them again would be good as the House begins debating that $880 billion bogey in terms of the budget reconciliation blueprint we talked about before the first vote. BCBSA features 10 policy proposals. You can view them in detail on the blog tab of my website, healthcarelabyrinth.com. The blog was posted on March 6th, so you can see all the details there. So most important, how do these cuts really break out? So the $1 trillion that the association has put out there is not absolute savings in the budget. The $1 trillion actually is a figure of healthcare system savings, and this is how that $1 trillion breaks out. There's about $524 billion in federal budget savings. There are $389 billion in lower private insurance premiums because of lower costs in the commercial and employer sector, and $180 billion in patient out-of-pocket savings. The reason I like this proposal is so much, again, about half of it is in federal budget savings, but the other half accrues to savings in the healthcare system overall. So first on their agenda, and we've talked about this in the past, is implementing site-neutral payments in Medicare. Blue Cross Blue Shield Association proposes sweeping adoption of site-neutral payments in Medicare. The association says this would save $495 billion over 10 years based on two proposals they are making. This savings is a combination of Medicare, commercial, and out-of-pocket savings. Again, this $495 billion is across the healthcare system. It is important to remember that most of the commercial rates out there piggyback off of Medicare rates, and that's why there are commercial and employer savings as well if you adopt site-neutral payments in Medicare. In short, site-neutral payments would pay the same amount for a given service regardless of where it is being furnished: a physician office, a freestanding ambulatory center, a hospital-owned off-campus facility, or on-campus hospital outpatient facility. It is unreasonable that hospitals expect to be paid more solely because they own a given facility or place of service. What's more, about half of all doctors are now owned by a hospital or health system, and physician practice patterns are changing. Hospital employers are now telling their physician employees to practice at more expensive owned settings. I've talked about this in the past. This is a huge drain on our healthcare system, serves as a disincentive for hospitals to be more efficient. It drives up Medicare and commercial coverage costs and increases member out-of-pocket costs as well. Hospitals spin that they serve sicker patients, that they deserve higher payments given what they provide a community, and that other facilities have lower quality. None of these arguments hold water in my mind, so I certainly endorse the concept of wide and sweeping adoption of site-neutral payments as the Blue Cross and Blue Shield Association proposes. Next on the association's list is enhanced antitrust enforcement. We know that the massive consolidation in the healthcare industry increases healthcare costs. Numerous studies show this, whether it is within the health plan industry, within the provider industry, or via vertical integration of payer and provider assets. The association says tougher antitrust enforcement could reap $78 billion in savings over 10 years. The Biden administration began tougher antitrust enforcement. The Trump administration looks so far to keeping the Biden approach here. So this $78 billion in savings certainly is viable as well in budget reconciliation. Next, let's get to the association's proposals on restrictions on provider all-or-nothing contracting. The association wants to prohibit excessive and abusive provider contracting demands. It says this would save $16 billion over 10 years. In short, hospitals and providers exert their power by demanding that health plans include the entirety of an integrated provider's assets in their network, oftentimes services and locations that are very expensive and not needed in a health plan network. This is called all-or-nothing contracting. As well, hospitals and providers demand that health plans do not use benefit designs that incentivize consumers' use of hospitals and the payer's network that offer high-quality care at lower prices. Again, these requests by hospitals during contracting are just ridiculous. They drive up costs for both employers and consumers by requiring expensive providers and locations be in network. The association's proposals would prohibit this and achieve those savings. The provider's use of these contracting provisions are clearly unreasonable and should stop. Next on the association's list are hospital administrative cost reporting and efficiencies. The association proposes that hospitals be required to report administrative costs and that caps be placed on their amount. The association says a recent analysis shows hospital costs from July 23 to June 24 increased by an amazing 6.9%. while inflation for all goods was 3.0% for that period. It also says that from 2019 to 2020, hospital administration costs grew by 6.2%, while clinical expenses only increased by 0.6%. Requiring that hospitals report admin costs and setting new cost efficiency standards for admin for hospitals could generate $40 billion in savings over 10 years. The association points out that insurers, through medical loss ratio requirements, have caps in law on most lines of business. It is hard to understand why we would not demand this from hospitals as well. Next on the association's list is expansion of value-based care in traditional Medicare. While value-based care, VBC, has been expanded and is growing in the traditional Medicare fee-for-service program, the association proposes to require provider system participation in two-sided VBC payment as a condition of participation in Medicare. This would mean providers have upside gain and downside risk when they provide services in the traditional program. The current fee-for-service system is only experimenting with these concepts right now and has much lighter forms of the alternative payment models currently. The proposal would also apply to Medicare Advantage. The savings, the association says, would be $54 billion over 10 years. While I understand the association's desires here, I have some doubts that many of the providers in the traditional fee-for-service system can truly make this leap. I would note, however, that a recent study did find that MA is having a positive effect on lowering costs in the Medicare fee-for-service system by changing provider behavior in that old transactional system. So maybe there is some hope of achieving this savings as well. The last area that I would talk about from the association, which has about 4 savings, is savings on drug reform to generate pretty major savings. And these 4 proposals by the association on drug reforms include eliminating the ability for drug makers to deduct spending on direct-to-consumer spending on their taxes, which would generate $137 billion in savings over 10 years. Next, shortening the exclusivity period for biologic drugs to 7 years from 12 years, which would save $134 billion over 10 years. Next, reining in drug maker tactics to delay the entry of biosimilar drugs to the market, which the association says would save $53 billion over 10 years, and requiring the use of 340B modifiers on all medical and pharmacy claims across all markets to improve transparency, which the association says would save $54 billion over 10 years. There's no question that facilitating the quicker entry of generics and biosimilars to the market and clamping down on the nefarious activities of brand drug makers is critical to lowering costs and aiding American consumers. So that is our quick review of the Blue Cross and Blue Shield Association's $1 trillion in savings across the healthcare system, but about $500 billion savings over 10 years for the federal budget reconciliation bill. So we'll take break 2 now, and when we get back from our second break, we will examine those Medicare Advantage cuts we talked about at the beginning. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We're talking about threading the needle, how the GOP may make reductions without fundamentally impacting coverage in America. We just discussed the Blue Cross and Blue Shield Association's proposals, which largely are centered more on provider cuts and payments and things like that. So now we're going to talk about the possible Medicare Advantage overpayment reductions. So again, despite Republicans liking Medicare Advantage, major funding and structural changes could occur. Some of you have written me asking why I am so convinced that the Trump administration and GOP Congress will continue to target Medicare Advantage for savings. It is true, again, that Donald Trump likes private insurance and MA as a program. His healthcare secretary, Robert F. Kennedy Jr., and Dr. Mehmet Oz, who is slated to be the administrator of CMS, both favor the program too. Trump and the GOP Congress could even opt for future beneficiaries to default to MA versus the traditional fee-for-service Medicare program. They could also offer some short-term relief in terms of MA rates in 2026 and pull back some misguided Inflation Reduction Act Part D cost-sharing changes, as well as pull back on their 2026 rule and some controversial things in there from Biden. But many of the folks with influence over Trump on healthcare hail from a conservative cadre of policy wonks who have long had MA's overpayments in their gun sights. These include Office of Management and Budget Director Russell Vought. He was one of the contributors to the Heritage Foundation's Project 2025. Other conservative policymakers have joined the administration as well, or have outside influence given relationships with Trump and his key advisors. As I noted earlier in the podcast, Paragon Health Institute is influential. Its president, Brian Blais, was in Trump 45, and several of his staffers and fellows are joining the White House or CMS in Trump 47. These policymakers do like MA again and propose various expansions, as I note. At the same time, they might be characterized as wonks who hate corporate welfare. Unreasonable subsidies to the private sector are anathema to the efficient functioning of government. There are GOP lawmakers as well with the same philosophical bent. That is why I have said that MA will see positive and negative developments under Trump 47. So let's review some of what Project 2025, the Paragon Health Institute, and others, both conservative policy outfits and beyond, have recommended to reform MA and make it more accountable. These proposals save tens of billions, if not hundreds of billions of dollars over 10 years. There are a number of permutations to many of these proposals, but I'm going to just summarize them for you. Capping or lowering payment benchmarks. Congress made a deliberate decision to set MA benchmarks in each county at a range of 95 to 115% of fee-for-service costs to promote MA growth, especially in suburban and rural areas. But the conservative policy wonks and some lawmakers say that this has to change now that MA has grown so much. So what would they do? They would lower the county benchmarks and perhaps cap them at 100% of the fee-for-service program in each county if there is sufficient MA penetration in a given county. They could lower urban rates below 95% of fee-for-service costs, and they could blend national and local benchmarks. In a calculation change, the policy wonks would calculate county benchmarks based on beneficiaries in fee-for-service with both parts A and B, not A or B. This would actually cost about $440 billion over 10 years and add 5.9% to rates. but they see this as a fairer method, especially if the cuts I just described above would occur. Further MA rate changes could be arbitrarily taking 10% or more cut from rates, blending MA encounters with fee-for-service experience to set rates, moving solely to MA encounter data to set rates, moving to a full competitive bid for MA. The wonks are concluding that fee-for-service rates are no longer a good way of setting MA rates as the program grows. They may be right. These wonks and lawmakers also are looking at risk adjustment changes. Disease states and conditions are analyzed for each member and a risk score is set. This is combined with rates to boost or lower the amount given the MA plan to cover the care of a member and recognize the risk. It is theoretically based, again, on the health risk of each member. But we do know that some MA plans are bad actors and abuse the system by engaging in overcoding in various ways. I continue to believe a subset of plans do this and gain a disproportionate amount of revenue. They give the whole program a bad name. Numerous risk adjustment and coding intensity changes could be adopted. These include increasing the negative coding intensity factor globally, which is a negative reduction to rates, increasing the negative coding intensity factor on a plan-by-plan basis, taking into account each plan's relative coding intensity, further refining the risk adjustment model to reduce overcoding, investing in aggressive risk adjustment data validation audits, blending 2 years' worth of diagnostic data before setting risk scores, eliminating diagnoses derived solely from manual chart and health risk assessments, and also having clear regulations related to risk adjustment changes as well as RADV. The current RADV rule is being challenged in court, in part because of some legally questionable provisions put in by Biden's CMS. You could also refine risk adjustment to include both prospective and retrospective components, and last, enact penalties for plans that do not provide complete, accurate, or timely encounter submissions. I am especially fond of reforms tied to HRAs and manual chart review, as well as a workable RADV audit process. I am intrigued by the plan-by-plan coding intensity concept. I think CMS is beginning to develop better risk models. Using 2 years of data has merit as well. Another area that the policy wonks and lawmakers believe could be ripe for overpayment reform in MA is ending star bonuses or making them budget neutral and revamping the quality program. The wonks object to the additive dollars put in for MA plans if they perform well in the STAR program, which evaluates MA plans on 40-plus clinical, drug, operational, and member survey measures. MA STAR is the only program where quality bonus dollars are added to rate dollars. The wonks and lawmakers recommend a number of possible things: ending the STAR bonuses altogether, making them budget neutral against rate pools, removing the rate rebate increases related to STAR performance, thus limiting bonuses to just those that get 4-star and above, ending double bonus counties, and converting to assessing performance at the local level and with peer groupings. Not all of the proposed changes will be adopted in a budget bill. How deep these cuts in STAR, in risk adjustment, and in rates overall go is anybody's guess right now. It may depend on how much savings they truly need. But the accountability push in the Trump administration and Congress will mean changes in MA over time, either in the budget reconciliation bill or as the Trump administration rolls out. MA plans should get ready and see how they can continue to thrive with a tighter belt. We will go to our last break now. We will close with our provider tax discussion that I promised. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Mark Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Mark's insights. Twice a week, Mark publishes a blog to go deep into a current issue. And of course, Mark hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Mark's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We are talking about how the GOP Congress and Donald Trump are trying to thread a needle to find spending reductions in healthcare, but not fundamentally impacting coverage. So far, we've talked about some Blue Cross and Blue Shield Association proposals that could save $1 trillion in the healthcare system, about $500 billion over time in the federal budget. These are largely more focused on provider rate and those kind of reductions. Just before the break, we talked about MA overpayments and how rate changes, risk adjustment changes, and even star bonus changes could occur to save dollars. And those could amount to hundreds of billions of dollars over time as well. Now we're going to go and talk about the provider tax in Medicaid. I mentioned in the introduction that the House GOP will likely see provider tax in the rubric of fraud, waste, and abuse by states of the system. Thus, they will say it's not really a penalizing or reducing reimbursement to states on a percentage basis or fundamentally impacting coverage. So let's talk a little bit about provider tax. Let's first talk about how Medicaid is financed. So, as I talk often about, Medicaid is a state-federal partnership. Both the federal government and states fund portions of the overall program. The amount a state receives is dependent on its relative wealth, with a floor of 50% reimbursement from the federal government for everyone. While reimbursement has been higher at points, including during COVID times, the federal reimbursement ranges from 50% at the low end to just over 77% in the poorest state, Mississippi. What are provider taxes in Medicaid? Simply, Medicaid allows states to levy taxes on providers to essentially raise state match funding in the Medicaid program. These taxes are most often levied on hospitals, nursing homes, and health plans. The provider taxes have certain rules, which I'll describe soon. The rules also allow intergovernmental revenue transfers from local government taxes to the state to match Medicaid dollars as well. In short, the ability to levy taxes allows states a way to fund its Medicaid expenditures needed to gain an equal or greater federal dollar match from healthcare spending. Last in this category, Medicaid also allows states to certify certain public health expenditures at the state level to meet state match requirements to leverage federal match in Medicaid as well. All but one state out there, Alaska, has at least one provider tax to help finance Medicaid in their states. All but a handful of states levy a hospital and nursing home provider tax. What do states think about a provider tax? States like the flexibility of provider taxes because they know it generates additional federal match that can go towards supporting Medicaid. Because every state receives a match that is at least what the state puts in, 50%, levying a tax and using the dollars to match the federal reimbursement means dollars are at least doubled for Medicaid. But since most states receive a greater than 50% match, as I noted, most states obtain more than a doubling of dollars. As a state budget director in Connecticut in the late 1990s and early to mid-2000s, I too used provider taxes on various providers to help generate revenue to support state match to gain the state a 50% match from the feds. In Florida, where I was on a Medicaid reform commission in state government, I watched as hospitals used intergovernmental revenue to maximize federal match going to them as well. What do providers say about such taxes? While such taxes are not universally applauded, Generally, providers have been supportive of the matching schemes and often come up with the machinations themselves to generate the federal matches. Providers have created a cottage industry to stay within federal rules, but create the greatest impact for themselves. Provider taxes have been reined in over time, though. Over the decades, the provider tax scheme became very abusive, and the federal government did reform and tighten rules. Currently, the following rules generally apply to the levy of provider taxes. First, provider taxes must be broad-based and uniform. They must apply consistently to all providers in a certain category and cannot be limited to Medicaid providers. Second, providers cannot be guaranteed to receive Medicaid payments equal to the amount of taxes they pay. There is a safe harbor rule that is an exception to this rule. Third, at least 40% of the non-federal share must be financed by the state, and up to 60% may come from local governments. In reality, though, about 68% of state funds come from state general revenues, 12% from local governments, 17% from taxes, and 4% from other sources. And fourth, levies must be approved by state legislatures in most cases. How do states and providers justify the taxes? Well, states and providers argue provider taxes and intergovernmental transfers allow states to meet state match requirements and ensure adequate funding for providers to care for those on Medicaid. They say restrictions on provider tax could lead to cuts in Medicaid spending, potentially impacting eligibility, benefits, and access to care. They counter arguments that the tax is not a state match. Sure it is, they say. It is a deliberate policy decision to tax and spend by the state. As important, proponents say that the taxes and transfers help promote equity and aid providers with safety net or low-income patient profiles. They also say it helps ensure an adequate number of providers in Medicaid. What does Paragon Health Institute and other opponents of provider taxes say? Arguments on the other side are that even with some of the reforms of the past, the use of provider taxes and intergovernmental transfers create a major excess in the Medicaid system. First, the schemes incentivize states to maximize federal match funds and minimize state contributions. Two, the targeted taxes minimize what states put in from general taxes. Three, the taxes and transfers are driving the share paid by the federal government higher, as well as Medicaid expenditures higher overall. The provider taxes help shift costs to the federal level. Fourth, even with changes, the provider taxes are abusive. Studies show that Medicaid in some states reimburse hospitals more than Medicare and are close to commercial rates. Fifth, the schemes are creating a huge unaccountable program and means hospitals and other providers are not incentivized to become more efficient. The third way, a center-left think tank, has found that hospitals can make a profit on Medicaid and Medicare rates as long as hospitals are run efficiently. Last, many of the provider taxes and transfers are creating supplemental reimbursement programs to hospitals, adding to base Medicaid payments. These can be separate from Medicaid managed care or directed by the state through managed care plans. These programs together create, again, a slush fund for hospitals. They don't really meet the intent of the Medicaid program and, again, do not promote efficient operations. So what are my views here? I see some of the opponents' views. I think the provider tax and intergovernmental transfers can amount to gimmicks, an effort by providers to drive revenue and not be efficient. I would note, too, that I am sympathetic to the concept of stopping very progressive states from driving ever-increasing costs by building Medicaid programs that are outliers from what might be characterized as reasonably comprehensive coverage populations and benefits. I fear that provider tax and intergovernmental transfers encourage this. On the flip side, I would also say that these schemes, these provider tax and other schemes, also may dissuade some states in the South from expanding Medicaid. I think upfront care is important, but the ongoing taxes and transfers flow dollars to hospitals to care for Medicaid and uninsured residents in very expensive ways. Those dollars would be better spent on upfront Medicaid expansion coverage. You can see this phenomenon of the supplemental payments playing out in Florida and Texas, which are the two largest states that have not expanded Medicaid. So, would I totally eliminate provider taxes and intergovernmental transfers to fund state matches? Likely not. Or if I did, I would have a slow phase out over a number of years so states could adjust. I might do the following instead. 1, lower the allowable tax percentage from 6% to 5% or 4.5%. 2, close some of the safe harbors in the current law. 3, stop new provider taxes and intergovernmental transfers. And 4, cap existing match in states with existing provider taxes and transfers. All of these changes across the board in the provider tax arena could save anywhere from about $50 billion over 10 years to over $600 billion over the time frame if you did eliminate these schemes altogether in one fell swoop. So there's a lot that could happen here. So let's sort of sum up here for a second before we conclude. Blue Cross and Blue Shield Association came up with about $500 billion over 10 years in federal savings and about $1 trillion in the healthcare system overall. Medicare overpayments could also amount to hundreds of billions of dollars over a 10-year period. And here you can see that provider tax savings could amount to as much or over $600 billion over the time frame. So we are talking several $1 trillion over 10 years in potential savings here. Now, I am not arguing that there won't be impacts on coverage. Certainly, if all of these were adopted, there would be impact on coverage. But it seems pretty clear that by reforming some very obvious areas of payment, whether I like them or not, provider taxes, MA overpayments, site-neutral payments, and things like that in Medicare, there is a lot of savings that could happen in the federal budget and the spillover effect that would occur in employer coverage as well. In my mind, government programs in toto, especially Medicaid, though, are on a crash course. And also, I would say Medicare. They are both fiscally unsustainable. Reform is needed. We just might have to look at these types of changes as well as broader ones over time. The alternative is either no Medicaid or Medicare or deep Medicaid or Medicare cuts further down the road. Would these changes impact coverage? Again, yes. But the current programs clearly need change. With that, we'll conclude this edition of the Healthcare Labyrinth podcast, and we'll see you next time. Take care.
Thanks for joining Mark and the Healthcare Labyrinth podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth podcast.